Thanks for coming, everyone. Welcome to our second Rheum 101 Rheumatology for non-clinicians session. As I say, thanks to the audience that are here in Manchester, and hello to those who are watching online as well. In fact, I don't think my mum will be watching because it's only the Antiques Roadshow that she watches. So just to remind us, what is UK Rheum? This is a UK Rheum event. It's a collaboration between 8 epidemiology centres in musculoskeletal research, and it's supported by Arthritis Research UK. And what is Rheum 101? Well, these are sessions about rheumatology for non-clinicians who are working in musculoskeletal research, and others are welcome too. It's an idea that came from the UK Rheum Statisticians Network, and it's to address this need that we've seen that non-clinicians have plenty of opportunity for training in methodology, but not so many opportunities for training in rheumatology itself. Today we're again hosted by the Arthritis Research UK Centre for Epidemiology in Manchester. We're broadcasting live online. The link's on there, but if you're watching, I guess you've got that already. We've got 2 more topics for you today, starting off with Immunology with John Reynolds, and then Lupus with Ben Parker. We're going to have a 20-minute presentation for each topic, and each one's going to be followed by 10 minutes for questions. People here in the audience can ask their questions in the traditional way, and if you're watching online, you can do so by using Twitter. The hashtag we have is Rheum101, and also by email. You can email rheum101@manchester.ac.uk. And there's a link on my slide there for a feedback form for people to fill in and tell us what they thought about today's event. Okay, so it's over to John Reynolds, who's going to tell us about immunology.
Okay, so thank you, Jamie. My name's John Reynolds. I'm one of the clinical lecturers here at the University of Manchester. And in 20 minutes, I'm going to try and give you a generalised overview of the immune system. And I think it's important to recognise that the immune system is inherently extremely complicated. So what I'm going to present is a close simplification, just to give you an idea of what it's all about. So I'm going to talk a little bit about what the immune system is and why we have one, about what it's made up of, and particularly I'm going to focus on the types of cells that are involved in the immune response. I'm going to talk a little bit about how these cells communicate with each other, because that's very important in some of the things that we measure in clinical and epidemiological studies. And then right at the end, I'm just going to very briefly bring up the idea of autoimmunity and what that is. So the immune system is composed predominantly of 2 separate groups of biological organisms. There are circulating cells, which are present predominantly in the blood, and also tissues which contain one or more of these different cell types. And the principal role, as illustrated here by the large arrow, is predominantly protection against infection. The immune system does have some other roles as well. It's important in wound healing and repair of body tissues, particularly after injury. And it also has a role in removal of abnormal cells, and the classic example here is cancer cells. One of the difficulties being currently that cancer cells have mechanisms to try and avoid the immune system, and there's a lot of interest at the moment in developing drugs to try and make cancer cells more susceptible to the immune system. And it's important just to bring in a definition here, in that cells within the immune system respond to very small proteins, which often come from pathogens. So the classic example that I'm going to use for the talk is bacteria. And these small proteins are called antigens in the context of them stimulating the immune system. And that's a term we'll come across again shortly. So the normal immune system you can think of as a little bit like a balance with scales, in terms of there has to be an equal amount of immune activation and also immune control. And if the immune system is underactive for any reason, then people will end up in a state of immunodeficiency. And this can either be hereditary, i.e. something that you're born with, or it can be something that's acquired either by certain infections or treatment with some immunosuppressant drugs. And in this situation, the host is at an increased risk of infection. The converse to that is when the immune system becomes overactive, and this is what we see in a lot of our patient groups where there's uncontrolled inflammation, the immune system is hyperactive, and this is often associated with the development of autoimmunity. So the immune system predominantly originates in the bone marrow, and the cells that are generated in the bone marrow move into the blood, and we're talking here predominantly about leukocytes, which you'll all know by the term white blood cells, and there are a number of different types of white cells. They live often in the blood, but move in and out of a specialized network of lymphatic vessels and lymph nodes called the lymphatic system. And the cells are often moving in and out at a relative pace. Other parts of the lymphatic system that are important for cells to live in and cells to be exposed to some of these antigens are organs that you'll be familiar with, like the spleen and the thymus, but also ones that you may not have heard of, and that's little patches of lymphatic system within other tissues. And the classic example would be something like the GI tract, which has got little patches of the immune system within some of that tissue, and that's often called mucosa-associated lymphoid tissue because it lives in the mucosal lining of the gut. It's obviously important, though, that the cells can move in and out of tissues, and they have roles and ways of doing that. Often it's unidirectional, so in the context of inflammation, cells move into the tissue but don't move back out again. But not all of the cells that we see in tissue come from the bone marrow. There are a small number of immune cells that you inherit from birth, and they stay within the tissues in which they develop, and those are often called resident immune cells. So people often divide the immune system into two principal components. There's one called the innate immune system and one called the adaptive immune system, and I'll talk about both of those briefly. So the innate system people sometimes think of as being a bit like foot soldiers. They are the first line of defense, and the innate immune system has got a very rapid action but very, very non-selective. It's got an important role in labeling pathogens so that it can flag up things that are foreign to the rest of the immune system, and it also has a role in sending danger signals. So in this World War I cartoon, the smoke is like sending danger signals to the rest of the immune system, but it's very broad. It isn't very selective at all, and can predispose to widespread inflammation. The adaptive immune system, however, is much more targeted. It's a slower response and is a little bit more like an airstrike. So it can selectively target specific things that what the host recognizes as being abnormal, and it's a very carefully orchestrated attack. The one thing that I'm not going to touch on for the rest of this talk is that the adaptive immune system also has a memory, so that when you've been exposed to a certain agent in the past, you can then recognize it later again if you see it, and that way the adaptive immune system can learn and become more rapid in its response. So the innate immune system is principally composed of anatomical barriers because the infection's got to get in somewhere, so there's a physical barrier that forms part of the innate immune system. There are a number of different cells, and the ones in blue I'm not going to talk about at all today, but the important cells that form the innate immune system are monocytes, which will then develop later on into a cell called a macrophage, and also a granulocyte, which is a family of cells, all with slightly different functions, but called so because they've got granules within them. And there's also a very important part of the innate immune system, which is not cellular-based, called complement. So if we think a little bit about the barrier is the first line of defense, and this cartoon represents cells forming that layer with the green fluffy things representing bacteria on the outside. And one of the important ways that bacteria gain access is that they penetrate between the gaps within the cells and get into the tissue. So in order to protect against that, these cells are held together very, very tightly with a structure called a tight junction, which means it's physically very difficult for the bacteria to pass through. In addition, some of these cells have got a specialized function in that they'll produce antimicrobial proteins, which can directly attack the bacteria and stop them from getting even close to the tissue. Anyone who's had any kind of infection will also be familiar with the context of mucus. There are specialized cells within the lining that produce thick, gloopy, proteinaceous fluid, which then stops the bacteria from getting in because it physically slows it down because it's caught up within the mucus. And there are also B cells, which I'll talk a little bit about in a moment, which produce antibodies within the tissue, all trying to protect from bacteria getting in the first place. An important concept within the innate immune system is this idea of phagocytosis. So this is the ability of cells effectively to eat bacteria and other pathogens that come along. So this, it represents a macrophage. The blue vesicle at the top is something called a lysosome. So what this is a little packet within the cell itself which contains enzymes which are toxic to bacteria. So if bacteria come into contact with them, they'll often die. And so what happens is that the cells have got receptors on the outside that can recognize different parts of bacteria. And when the bacteria and the receptor come into contact, then the bacteria will get taken up inside the cell and sit within a little sac inside the cell. And it doesn't take too much imagination to realize that when these two sacs fuse, the bacteria then become exposed to these enzymes. And this is a common method of bacterial killing. The complement system is difficult, and I think many medical students have suffered trying to understand the complement system. Basically, it's a number of proteins which are all soluble, and they're all produced by the liver, and they exist in two forms, either inactive or active. And there are a number of different ways in which this pathway can become activated, and I'm not going to go into that in any detail, but there is a very common unifying step within that. And the role of complement is basically threefold. One is that it recruits some of these phagocytes that I talked about on the previous slide to sites of inflammation. The second is it acts as one of the mechanisms of danger signals, so the complement will stick to the surface of bacteria and then label that for the immune system to recognize as being foreign. And this is a process that's called opsonization. And the third thing is that the complement can kill bacteria directly, and so some of the complement proteins will form into a ring-like structure, which will attach itself to the surface of the bacteria and effectively open a hole in the bacterial cell wall, and the contents of the bacteria will come out, and that's the way the bacteria dies. It's a little bit like those Hollywood movies where people poke a hole in the side of an aeroplane and everything gets sucked out, and that's known as the membrane attack complex. I thought Ben might talk about this a little bit, but it's important to recognise that this is not an endless supply of protein, and in situations where this system is active a lot, the amount of complement that's measured in the blood can fall, and that's something people will sometimes term complement consumption. So some of the diseases that we deal with, low complement is a hallmark of that, and that's because this system is overly active and it's not being replaced enough at the top. And so the levels of certain complement components will fall. So on to the adaptive immune system. This is the cleverer part of the immune system. This involves predominantly two types of responses, and I'll touch on both of them briefly. One is that there's a cellular response, and the second is an antibody, and sometimes you'll hear the term humoral response. That means the same thing. And the most important cell type in this kind of response are lymphocytes, and these are both B and T lymphocytes, named predominantly because of where they mature, T cells in the thymus and B cells in the bone marrow. And this is a complicated diagram, and the only point I really wanted to make is that these cells are very different from the cells that I talked about earlier. So the cells that form most of the innate immune system are those ones in red, but these cells come from a very, very early cell type, which is fundamentally very, very different from the rest of the cell types. So you can think about these and the granulocytes I talked about earlier as being very, very separate. And one of the roles of these cells, particularly of the T cell, is to recognize antigen. So antigen is that bit of protein that I mentioned right at the beginning. And there are certain types of cell that can hold that bit of protein up to the immune system for it to be able to see it. And these are termed antigen-presenting cells, and the principal way of doing that is that the antigen sits in a protein receptor on the outside of the cell called MHC, and a lot of you will have come across that term before. And it's this complex of the antigen within the pocket of the MHC that the rest of the immune system is then able to have a look at and see whether it recognises this as being foreign or not. So T cells therefore have a complementary receptor, so the two things act together. And it's interesting that every T cell has a unique receptor. The cells undergo a huge amount of genetic rearrangement so that every T cell receptor is different. And that's very important because you want to be able to recognize any possible antigen. So what happens is the two things combine, and then there's a series of secondary signals that comes out from the antigen-presenting cell, telling the T cell what to do depending on what it sees. So if it sees something that's abnormal, say a bacterial pathogen, for example, then the immune system will become activated, the T cell will go on, it'll go on to divide, it'll go on to change into different types of cells, it'll go on to help the rest of the immune system mount immune response. If, however, it doesn't like what it sees, so it's something that it doesn't really understand, it's never seen it before, it's perhaps a self-protein rather than being a bacterial protein, then the T cell will either just move off and not really do anything and carry on its merry way, or in some cases it'll be put to sleep, just in case it looks a little bit like something that belongs to the host. And there's a process by which these T cells, as they're developing, get shown this different type of antigen. And if they bind too strongly to it, or they recognize antigen that you don't want them to recognize, i.e. your own tissues, then those cells get deleted. And this is a process called immunological tolerance. When we think about T cells, there are two principal ways that they're useful. There are lots of different subtypes of T cells, and I'm not going to go into those. The ones you'll come across are the cytotoxic T cells, which are, people sometimes talk about CD8 cells, because that's a marker that they have. And their role really is to kill infected cells. So if you have your own cell infected by a virus, for example, this gets flagged up to the immune system, and it's this cell type that comes along and destroys your own cell because it's got bacteria within it. The second is the helper cell, and this is the cell that helps to promote the antibody-based response. And the way it does that is that it talks to B cells. And sometimes people will use the term CD4 cell, which is interchangeable with helper cells. And so these are cells that help the B cell to then start go on and produce antibody and do other things. So as I alluded to on the previous slide, the role of the B cells predominantly is to produce antibody. And the way they do that is that some of these B cells will change into something called a plasma cell, which is effectively an antibody-producing factory. And they produce antibodies only against the antigen that they were stimulated to do so. So they can't sort of switch between one antigen and another. And they come in different flavors, the antibodies, and they've all got slightly different roles. And what antibodies do is three principal things. One is that they neutralize things. So if you've got inflammatory proteins, bacteria or something, the antibodies can stick to it, and then it can't go on and cause any problems because it's just covered in a layer of antibody. A bit like complement earlier, it undergoes this process. It can cause opsonization, so i.e. labeling the bacteria to the rest of the immune system. And it also can activate complement. And so this is an example here of where the adaptive and the innate immune system are working in harmony. So cells can talk to each other either directly by this mechanism I talked about earlier, or they can also send signals from one cell type to another. So this is a bit like a carrier pigeon, for example, and these proteins are called cytokines. They can be produced by one cell type and then go and stimulate other cell types. And we measure these quite commonly, and they can either act on the cell that they were produced by or go on and pass messages on to other cells. So very finally, for the last 2 minutes, I'm going to very quickly touch on autoimmunity. So this is what we would normally hope the immune system does, i.e. it recognizes foreign antigen, and then if this is something that we don't want to see, like a bacteria, you produce an immune response. But what you want is that when it sees self-antigen, which is proteins from your own body, that it doesn't activate. And what happens in autoimmunity is that this goes wrong, and predominantly it's the loss of the ability to recognize self from non-self. And then people will develop autoreactive cells. Those are cells that recognize your own body's antigens, and both B and T cells will be developed. And then eventually you produce antibodies against self-proteins, and you'll be familiar that autoantibodies is something we talk about a lot in the context of rheumatic diseases. So the final slide, the summary is that the main role of the immune system is to fight infection. That immune responses are classically divided into this idea of the innate immune system, which is very blunt, and the adaptive immune system, which is much more clever, but often these two things work together in unison. And many rheumatological diseases are autoimmune in their nature, and fundamentally that's because the immune system is unable to differentiate between self and non-self, and thus mounts an appropriate response. And that is the end. I'd like to thank you for your attention, and I'm happy to take any questions.
Thanks, Ben. John, even. Ben's in front of me there. An amazing job, really, in taking such a complex system, such a complex thing, and explaining it to those of us without clinical background in under 20 minutes. So thanks very much. If anyone has any questions here in the audience, please just put your hand up, and then anyone that's watching online, you can submit them via Twitter. The hashtag is Rheum101, and by email is rheum101@manchester.ac.uk.
Hiya, that was great, thank you. If every single T cell has a different antigen receptor and you get stabbed by something in one part of your body, isn't it ridiculously improbable that that one cell will find, if there's so many circulating around?
Yes, so what happens is that's the function predominantly of the lymph nodes and the spleen, is that the antigen-presenting cells sit in those organs and are constantly holding up the antigen, and so the T cells move in and out of the blood into those organs. They circulate, they look around, a bit like finding someone you want to chat to at a party. You go in, you have a look around, you see if there's anyone you want to talk to. If not, you move out into the next room and then do the same again. And that's the process by which the adaptive immune system tends to work, which is one of the reasons it's so slow to begin with. I mean, there is a little bit of overlap, because although each receptor may be unique, there may be a number of receptors that can do a good enough job of recognizing the antigen that we're interested in.
So you just teased us at the end there, John, with talking about autoimmunity. I guess an obvious question that springs to mind there is about how that develops. Are there many different mechanisms in which autoimmunity can begin?
So there are a number, and the idea that I like the most is that there's something genetic and then there's something environmental. And so a good way of thinking about it may be that if you've got an abnormality in your MHC, and you'll all be familiar with HLA, and HLA is the gene that encodes MHC. So if you've got a certain type of HLA, then your MHC that's sitting on the surface of the cells looks a bit different. And there's something then about when it holds up antigen to the rest of the immune system to look at, that it can look a little bit like self. So for example, if you have a viral infection, it may be that in that complex of MHC that you've got, that looks a bit different to somebody else's, that when that combination of the virus protein within the MHC looks like one of your own tissues, and your body then can't distinguish it, because part of it's saying, well, this is a virus. But part of it says, yeah, but it looks like skin. But it's virus, but it's skin. And that's kind of one of the theories about how autoimmunity can develop. But there are a number, and we still don't really understand it.
Okay, thanks. I've got a question here that's come in by email from Leo in Southampton. And Leo asks, why is it that increased inflammation is more likely to occur with older age?
Ooh, that's a good question. Hi, Leo. So one of the reasons may be that your ability to have this idea of this tolerance that we talked about in the adaptive immune system, one of the reasons may be that you lose that ability as you get a little bit older. There are lots of other potential reasons in that all of your cells become less responsive. And so there are a huge number of changes, but I don't think we fundamentally understand why inflammation is more problematic as you get older.
Hi, John. Thanks. You talked about inflammation and how it's a part of the immune response. I was wondering, how do steroids work in reducing inflammation?
Yeah, that's a really good question, and that's a question that we do not fully understand the answer to. So there are people still, even though we've been using steroids for over 50 years, there are still people trying to understand exactly how they work. We know that it changes the population of immune cells that are present in the blood. We know that it reduces the amount of some of the cytokines that are the messengers between the cells, but the exact mechanism by which it does it is very, very complex, and we don't really understand, because steroids can regulate in the region of thousands of different genes. And it's something to do with switching on or off certain genes, but we don't really understand exactly how that works, and people are still doing work on it now, even though we've been using them with good effect for so long.
Okay, if you have no further questions, then thanks again, John.
Thanks.
And we can welcome our second speaker, Ben Parker, who's going to tell us about lupus.
Little sneak preview of later on. Right, hello everybody, my name is Ben Parker, I'm a rheumatologist over at Central Manchester, and I have a special interest in lupus both academically and clinically. And almost as if this had been planned, I'm going to talk to you about lupus, which is an autoimmune condition where maybe a couple of topics that John has mentioned will be discussed. However, like the immune system, lupus is a rather complex beast that might take more than 20 minutes to get across to you. So we're going to cover a few key things, and in red as we go through, there's just going to be a few little tips for people who might be involved in academic research in lupus as to how to look at things a little bit more critically, maybe data sets or articles. But also what I'm not going to cover is quite a lot, and that's because these probably need a session in and of themselves, and it may be that if this goes well and carries on, then part 2 will follow at some point in the future. However, these are no less important, they are perhaps just not basic. So we'll start off with the question of what is lupus, should I say. Now, if you go to any textbook or review article, it will start off with the simple line that lupus is a multi-system chronic inflammatory autoimmune disease. Each of those can be broken down into its component beings, but leading on from what John has said, it is a disease of your immune system recognizing self as non-self, which often leads to the production, which we measure clinically, of autoantibodies, which are classically against proteins that are often found inside the nucleus of the cells, which you can imagine your immune system should never really see the nucleus of your cells. Clinically, it's characterized by being a relapsing remitting disease that has both inflammation and long-term damage, and that's quite critical in much of rheumatology. However, unlike many other musculoskeletal conditions, it is quite heterogeneous. It is very difficult, which presents challenges to manage, to diagnose, and equally challenges to research, because one person's lupus looks very different to another person's lupus. And just to put it into context where lupus fits, I think one of the things that's quite important to understand is the spectrum of musculoskeletal or rheumatological diseases. And very broadly, you can divide those up into inflammatory conditions and non-inflammatory conditions. And lupus fits under the connective tissue diseases box, of which there are many others. And therefore it is often not a disease in isolation and often shares overlapping features. So from a researcher perspective, if you're looking at patients with lupus, it all comes down to, is my lupus the same as your lupus, is the same as somebody else's lupus? Because often your research findings or your clinical trials will stand or fall on that simple question. It's very different to diabetes. You've got diabetes, you don't have diabetes. So, how do we recognise lupus, and what are the clinical features that make us think so? Well, there's many, many, many different clinical features, and what I won't do is spend the next 20 minutes showing you lots of photographs. However, I will show you a few. This is the general summary of systems that can be involved in systemic lupus. So lupus is a disease that is multi-system, so every single system of your body, almost without exclusion, can be affected in lupus. And we can go around them, and there's lots of subheadings within there. So one of the complexities of lupus is that any patient can have any number or combination of these conditions. So one of the key things to remember is there's no standard way a lupus patient will present, and no standard way that you can say, I only see this condition in lupus, because most of these things will appear in other conditions as well. However, the skin, for instance, is very, very commonly involved in lupus, and can be involved in any number of ways, and can be very what we call inflammatory, so very red, very angry, very sore, very itchy. Think of hives, think of sunburn, think of prickly heat, very inflammatory skin conditions. But in lupus, what often happens is you get quite profound sensitivity to the sun, which can be very damaging and make you feel generally unwell. If your scalp is affected, you can get inflammation of the scalp, your hair falls out and never grows back again. You can get alopecia. And the classic skin condition is this thing called the butterfly rash. And whenever you see lupus, you'll see a little butterfly or a wolf mentioned in terms of imaging. I've tried very hard not to include it. It's not something I necessarily think is always that helpful. This is a musculoskeletal research group, and lupus patients can get musculoskeletal joint problems. They get inflammatory arthritis quite a lot. So they can look a little bit like rheumatoid arthritis, of which you've had a talk before. There is a common key difference between patients with rheumatoid arthritis, in whom the inflammation often causes damage to the bones underneath. In lupus, it often doesn't cause damage to the bones underneath. However, it looks as though it is. And that's a rather complicated way of explaining that they get correctable deformities in lupus, and that's quite a characteristic finding. The other system that's quite commonly involved in lupus, so skin and joints are very common. The other system is this thing called serocytis, and this is a concept that each of the internal organs is often lined by a lining of membrane that, when it's irritated or inflamed, will produce fluid, and fluid can collect in that cavity. So if it's happening in the lungs, you get inflammation of the lining of the lungs. It causes pain when you breathe in and breathe out and cough, but it also causes fluid to build up in the cavity of the lungs, which causes breathlessness. And the X-ray on the left is showing what's called a pleural effusion. That's bad enough, but it can sometimes happen around the lining of the heart as well. And you can imagine if the heart is in a sack of fluid, it struggles to pump properly, and therefore patients can become quite unwell quite quickly. It can also happen in the abdomen and causing recurring abdominal pain. So what you do find often is that lupus patients will have these, and they'll either be clinically quite mild or can be quite devastating, and anywhere in between. Less commonly affected, although not rare by any stretch, is lupus in the kidney. And inflammation of the kidney is a thing called nephritis, and nephritis is the thing that often dictates how well or badly patients will do in terms of their outcomes, in terms of what treatments they get put on, and how long they live. And nephritis, 40, 50 years ago, massively reduced your mortality. Now, it is treatable and manageable, but not in everybody. And one of the challenges with nephritis is it often isn't causing any symptoms until your kidneys have stopped working completely, by which point you have missed the opportunity to intervene. So one of the things in lupus is that some clinical features are very, very obvious, and some are not. And some have to be actively looked for to be able to diagnose and manage. And another common feature in lupus, and it's common to a lot of connective tissue diseases, if you have a talk on scleroderma or if you have a talk on myositis, is this thing called Rhea Nodes. And Rhea Nodes is really quite a troublesome, unpleasant symptom. Less bad than in scleroderma, but still bad enough to cause quite an issue with quality of life. And you can see that that's a very white finger, which if you put a heat-sensitive camera on, you'll find there's absolutely no blood supply getting into those fingers. But the key thing about Rhea Nodes is it goes across the connective tissue diseases. So that first diagram we had with overlapping clinical features, this is a key concept that a lot of these things I've just talked about can occur in other diseases. So there are multiple potential clinical features. Importantly, they often cluster within an individual. So, for example, skin and joint disease often go together in the absence of any internal organ involvement. Severe features are more common in non-Caucasian patients, and that's a key concept in lupus. It doesn't mean to say that Caucasians don't get severe lupus, they certainly do, but in terms of the frequency, the prevalence, the risk of those occurring, they're much higher in non-Caucasian populations. And some features are difficult to diagnose, but will dictate therapy and will dictate outcomes. And from that, I think about kidneys and brain disease can be quite tricky to pick up, but certainly will dictate the treatments that they go on to. And the important thing is that if you're researching mechanisms of disease in diseases like lupus, it can be quite hard if you've got that multiplicity of presentation to find something that runs through every single person with lupus. So often what the research that we try to do is to try to separate out groups of patients, patients with kidney disease or patients with skin and joint disease or patients with certain antibodies. It's likely that those pathways are more common if you restrict the population that you study. So who gets lupus? Well, there's a few key things about lupus. It's much more common in women. It's much more common in your 30s and 40s, just as you're trying to start a family. And there is an ethnic gradient in prevalence and severity that we've talked about. And if you look at the UK, this is a community-based study of general practice, and this shows that the peak age of onset is in around the late 30s, early 40s, and again with prevalence. But earlier studies have shown and confirmed this ethnic gradient in lupus, and clinically this is very, very important. And the base rate in Caucasians is around 20 per 100,000, but you can see if you're Afro-Caribbean or Black African, you've got a rate around 5 times that amount. So certain populations have quite a significant burden of lupus compared to the Caucasian population. Now, what I won't do is go into any great detail on the immunopathogenesis of lupus. Suffice to say, John has introduced a few key topics around loss of tolerance and autoimmunity, and how the immune system has different components that produce antibodies and cause damage. All of those are relevant in lupus. The key things to remember is that it involves a loss of tolerance that John's talked about. This is very complex and is due to combinations of genetic and environmental risk factors. Your immune system then will produce autoantibodies against nuclear antigens, and these form what are called immune complexes, whereby your antibody and your antigen interact and trigger the immune system, and that triggering causes inflammation, often through what John's already talked about, things like complement, which attack cells. Complement is very, very important in lupus when you're considering how the patient presents and what's going on in the organs underneath, and it's activated by both sides of the immune system. The immune system being activated can lead to very non-specific features, which is often why people have a slightly delayed diagnosis often. It can cause fatigue and glands to swell up and feeling generally unwell, but also it can cause very, very specific illness if that's occurring in a tissue like skin, which causes rashes, or kidney, which causes nephritis. So often lupus patients have a combination of very specific symptoms and very vague symptoms. And this is just a fairly simple schematic to show that how patients get kidneys. It starts off with a problem with the immune system, which goes on to cause immune complex deposition, which if it occurs in the kidneys causes an inflammatory response within the kidney. And you can imagine that membrane attack complex in your kidney cell punching a hole in your kidney cell, and that kills the kidney cell, and therefore you get kidney damage. When you think about the etiology of lupus, there's lots of clues as to how complex it might be. There's definitely a genetic component, and there's definitely an environmental component, and in between there is an interaction to go from one to the other. What that is and how that happens remains slightly unknown, but certain things have been identified, but no one trigger has been confirmed in any particular population. I won't go through the long list there, but there are genetic factors. There's multiple genetic factors been identified. There's factors that happen to your immune system while it's developing, both in utero and in early infant life, that will direct it towards an autoimmune phenotype. And then there's definitely triggers later on in life that can add up together to push people into an overt disease. So how do we diagnose lupus? So the key thing is there isn't a test for it. There's lots of complementary things that support a diagnosis, but the key thing around lupus and most of rheumatology, what the patient tells you and what you can see when you look at them is probably the two most important things when diagnosing any rheumatic condition, but lupus in particular. The tests are supportive. The problem with that approach is it often means that patients have missed diagnoses or a delayed diagnosis, as it depends who they see and when. And it's important to remember that classification criteria, which we'll talk about next, are great for research, not so great for clinical practice, as not everybody meets those criteria even though they have disease. And what that means from a research perspective, if you're looking at cohorts of patients with lupus, they can be quite varied, and that variation will result in outcome variation depending on what you're looking at. So if you have a Caucasian population, you might not have very much renal disease, but if you have an Afro-Caribbean population, you'll have quite a lot of renal disease. So if renal disease is your outcome, Depends entirely on your population makeup as to how, if you'll find anything of use. So diagnosis is complicated by the fact that disease is difficult to assess. This is a talk in its own right, so I'm not going to focus on this very much, but suffice to say that inflammation is not the only thing that presents problems in lupus. We saw the picture of the Reynolds phenomenon. That's not inflammation, that's a blood vessel shutting down into vasospasm. Okay, that's nothing to do with the immune response per se. Lupus patients also have a clotting tendency a lot of the time, so some manifestations might be due to blood clots like a DVT. And repeated episodes of inflammation will leave behind scarring and fibrosis. So the key thing in lupus and many other rheumatic conditions is that the pathogenesis of any feature may be different at different time points in different patients. So clinical studies of therapies in lupus must distinguish between that. There are classification criteria. These are a research tool rather than a clinical tool, and they're listed here. The actual details of that aren't that important, but they are there and they exist. We talk about anti-nuclear antibodies, and we talk about antibodies against components of the nucleus, and it's worth just pointing out that although this is a good test for lupus, they appear in many other things. So one of the diagnostic challenges is the relevance of tests that we use. However, there are more specific antibodies against components of the nucleus which are more helpful, although again, listed here, as you can see, the details aren't important, but what you can see is they're not all just occurring in one disease, there is overlap. So briefly, the management of lupus, ideally, is diagnose, treat, monitor, and rationalise therapy. But as you probably understand, that doesn't always happen, and patients go back to the beginning of the journey at any particular time. So studying cause and effect in lupus can be quite challenging because patients are at different points of that journey. Suffice to say, the initial management of lupus and the overall aim is to establish a diagnosis as quickly as possible, introduce some lifestyle avoidance things like sun and certain agents that can make lupus worse, but also try and prognose that patient. Have they got high risk for kidney disease? Have they got the wrong antibody profile, etc.? There's then drug therapies that can be instituted at any level, at any time point. Unlike rheumatoid arthritis, which has a sort of treatment ladder, lupus is often dictated by the severity of the manifestation that you're managing, and therefore some people will go straight into the last line of therapy, whereas some people will go through that process. It's worth remembering that not only is disease the thing that directs treatment, but how the clinician and the patient feel is also very important in clinical practice. Lots of drugs are used in lupus, but the vast majority of patients are on antimalarials. Steroid use is still quite high, and then levels of immunosuppression will depend on the cohort makeup and the severity of the disease, and we are in the era of the biologic drugs in lupus. Which leaves me briefly to finish on unmet need in lupus. Now, this is not a core thing, but I think it's quite useful to talk to a population of researchers, because there's lots to research in lupus. There's lots of problems that we don't understand, and here's a few, some of which would be topics of other talks, some of which are cutting-edge research, but there is a lot of unanswered questions, and that translates into a high burden of need for patients. A couple picked out is mortality. Lupus does and will kill people. It's one of the few connective tissue diseases that has a significant mortality rate. Before the advent of steroids and dialysis, it was around 50% at 5 years, all due to untreated kidney disease, but we've got better over time. However, it's 85% at 10 to 15 years, which if you're 30 at diagnosis is not that reassuring. The mortality rate is higher in younger patients, and the causes of death are quite varied. Kidney disease, infections, malignancy, cardiovascular disease. So there's lots of things that cause patients to die. And one of the problems we have is that we have limited treatment options in lupus. If I put this slide up in rheumatoid arthritis, I could fill it with a variety of different biologic treatments that are all very effective. I can't do that in lupus, unfortunately, and steroids often remain the base treatment. And the history of lupus is one of littered, failed clinical trials. And the key thing, I think, the reason I put my little red points on, is that much of that is due to the misunderstanding of the disease in itself and how to assess it. So one of the key things that we've learned along the way is all the basic things about lupus will dictate whether or not clinical trials are successful, and that opportunity has been missed, and a lesson that's been learnt in quite painful circumstances. So to finish, lupus is a complex disease with a very clinical presentation and prognosis. It remains challenging to diagnose and manage. It has a high burden of disease, comorbidities, and treatment side effects. But knowledge of the disease is vital when you conduct research, so you get the right answer. So thank you very much. I'll leave it there.
Thanks, Ben. Great talk. Obviously, covering what's a very complex disease in a way that us non-clinicians can understand. And I guess an obvious first question for me is, it does seem such a complex disease. In what sense is it really one disease versus lots of different diseases which, for whatever reason of history, have been pulled together under that label?
I think it's an accident of history that every disease that has been pulled under one label. So it's, if you think about rheumatoid arthritis, people often talk about two types of disease and a multi-system disease, and maybe three types of rheumatoid arthritis: seropositive, seronegative, and then the systemic disease. I think lupus is lots of types of lupus under one umbrella, and I think the key thing is understanding what drives certain types of lupus, because targeted treatments will be better at the underlying cause rather than what the patient is presenting with. So the key research area at the minute is, can you identify different underlying problems that would dictate what that patient presents with? But you're right, it's not one disease.
Thanks. So we've got a question come in here from Marie in Manchester. And she says, just wondering, are the specific antinuclear antibodies a good diagnostic criteria? And so she says, for example, can the anti-Rho and anti-La antibodies, if that's correct, be found in people that don't have an autoimmune condition, or are they only found in people that have SLE or Sjogren's syndrome?
It's a good question, Marie. Short answer is they're not a good diagnostic test for lupus, in as much that I skipped over it slightly, but all of the antibodies that we see in lupus are seen in other conditions and in healthy people. So neither is it a diagnostic test, nor is it particularly relevant if you haven't got lupus but you have an antibody. So there's two problems on that equation. One is you've got the disease but don't have the antibody. So what does that mean in terms of diagnosis? And the flip side is you have the antibody but you don't have a disease. And that's equally diagnostically challenging for the person on the receiving end. So unfortunately, all of the antibodies can occur in health, other diseases, and in lupus.
Thanks.
Hi, Ben.
Hello.
So you showed that mortality is higher for sort of younger adults who get lupus. Is it even higher for children who get lupus, or is it different?
So childhood lupus is slightly different to adult lupus. The genetic component in childhood lupus is much more, so the disease is slightly different. But one of the reasons the rate ratio for mortality is higher in younger is because the background mortality is quite low. So even if you have a low mortality, absolutely, the ratios are quite high. Whereas as you get older, other things start cropping in. So yes, there is an elevated mortality in lupus in children compared to children without lupus. But that's very much, again, driven by the fact that mortality in childhood is low.
So I guess lots of us would be used to hearing about lupus as a disease with periods of remission and then flares of disease activity. Why is that the case, and is that destined to be the case for everyone?
Why that is the case is not very clear, and no, it's not destined for everybody. There are some patients who have a fairly relentless march of clinical activity that is refractory to any treatments that we give. They tend to be the younger patients, often non-Caucasians, but can be Caucasians, who just don't respond and are refractory rather than relapsing and remitting. Relapsing and remitting, why that happens, that would be a very good answer for any autoimmune condition and any sort of inflammatory rheumatic disease. It's important to recognise, because sometimes when you see patients, they're in the remitting phase. And if you only see them once a year, you may miss that. And if you're recruiting them into studies, if you see them when they're in remitting phase, you get a very different picture in terms of the data that you collect on that particular person, so your outcomes are often diluted. So it's important to appreciate that study design has to allow for the fact that disease goes up and down on its own accord, regardless of what you do.
So you mentioned the butterfly and the wolf often being used in lupus. So we understand the butterfly from the butterfly rash, and we know that lupus is the Latin for wolf. But can you explain what the wolf connection is to us?
So the connection really is in a form of rash that patients used to get that they used to avoid the sunlight. So that only the theory goes that patients would not come out in the daylight because it would aggravate a rash, and therefore they came out at night. So you're thinking around moonlight and you're thinking around wolves and werewolves. So that's probably where that came from. It's a little bit unhelpful because lots of things cause rashes that get worse in the light. So it's difficult to say that's a purely lupus phenomenon.
Thanks. If we've no further questions, then I'd just like to thank both our speakers for today. So thanks to Ben and thanks again to John. And if I could just finish by asking everyone that's here present to fill in one of the feedback forms that you have, hopefully not too far away from you. And if anyone's watching online, I just bring up the address again. I can show you the URLs on the screen there where you can give us feedback. So I'd be really interested to hear what you thought of today's session and ideas that you have for the kind of things you'd like to see in future sessions. Thanks very much.